Hey everyone, my name is Rachel. I'm one of the PGY1 Ambulatory Care Pharmacy residents, and I'm really looking forward to seeing you all in class soon. Today we will be going over allergic rhinitis and cold and cough, and these slides have been adapted by some of the previous residents, including Chris Walston and April Anderson. And here's a quick overview on what topics we're going to be talking about today.
We're going to start off by discussing allergic rhinitis, and as you can tell from this picture here, most of the symptoms are related to runny nose or postnasal drip, itchy nose, throat and eyes, that's why they're red and swollen, and can also experience some sneezing as well. Allergic rhinitis affects roughly 15 to 20% of the U.S. population, and it's the fifth leading chronic disease in the U.S. and the third leading chronic disease in pediatrics. And in a lifetime, it will affect up to 30% of adults and 40% of children. It gradually declines in later years of life, so you won't see as many geriatric patients with allergic rhinitis as you will younger patients. And in our younger patients, it seems to be more common in boys than girls. But then after that adolescent stage and into adulthood, there becomes a smaller difference in sex between the difference of presence of allergic rhinitis. Also, another risk factor for increased likelihood of allergic rhinitis is higher socioeconomic status. Typical symptoms of allergic rhinitis include things like sneezing, itchy nose, itchy eyes, throat or ears, clear rhinorrhea, so like clear fluid draining from the nose. That could be out the nose or postnasal drip, watery eyes, nasal congestion, cough, conjunctival edema, itching, tearing, or subocular edema or darkening. That's called shiners, or mouth breathing and or sleep disturbances. So we're going to start off by talking about some non-pharmacological strategies to mitigate allergic rhinitis. So some of the things that you may want to consider are when we start talking about medications, using those prior to a known allergen exposure. Like, for example, if someone knows that they're allergic to cats and they know they're going to go over to someone's house that has a cat, trying to medicate prior to that exposure is more beneficial than waiting until later after the exposure. Another thing non-medication related you can do is in your home try to set up HEPA filters. That cleans and purifies the air a little bit better. In general, obviously it's easier said than done, but avoiding allergen exposure such as smoke or animals, whatever triggers the allergic rhinitis, trying to avoid that if at all possible. Can also wear a mask or goggles or other protective equipment. This is especially beneficial if patients are allergic to grass, or if they have to mow the lawn, things like that, or if their occupation exposes them to something that causes or triggers their allergic rhinitis. Obviously, keeping the windows closed in the home instead of letting the outside allergens in that may trigger their allergic rhinitis. Minimizing carpet in the house is an easier way to also mitigate this. Carpets tend to trap and keep dust and other things inside them more so than laminate or hardwood, things like that. And obviously keeping your home clean and tidy and trying to keep the humidity low is also best. And then trying to control pests, and then watch pollen counts as well as we go into the spring. I'm going to go into the drug class more specifically on the subsequent slides, but on this slide I just want to bring up the comparative efficacy for each of the agents we're going to discuss for allergic rhinitis, and then their efficacy for each of the symptoms that may be more predominant in one of your patients. So this can kind of help you drive your selection choice of what agent you may use, depending on what symptoms are most bothersome to your patient. So antihistamines are pretty good across the board, but especially if your patient is having sneezing or rhinorrhea, that clear nose drip or postnasal drip, antihistamine seems to be really effective in this area. Likewise, intranasal steroids across the board seem to be really effective. and have better efficacy than antihistamines in the congestion area and equal efficacy in eye symptoms. And decongestants, they don't really help with anything other than congestion. So that's easy to remember. The name decongestant only works for congestion for the most part. Has a little bit of symptomatic relief for like eyes, but otherwise just think of it as only using that for congestion relief. And the leukotriene receptor antagonist, Montelukast, is minimally effective at reducing symptoms from each of these things, but not as great compared to antihistamines or intranasal steroids. Continuing into some clinical scenarios you may encounter, this slide gives you an idea of what recommendation you should be making based on the given scenario. So let's say your patient comes in with intermittent sneezing, itching, and rhinorrhea. Your recommendation could be one of two things. It could be an oral antihistamine or an intranasal antihistamine. Again, right now we're just going to kind of review the class, and I'll give you some specific examples of medications in each of those classes in the coming slides. Next scenario you may encounter is just nasal congestion or persistent symptoms after treating with other things. You may want to consider, in this case, an intranasal steroid or an oral decongestant. If someone in general just has mild symptoms, they're experiencing a little bit of everything, the sneezing, coughing, eye symptoms, everything, you may want to consider one of the more versatile agents such as an oral or intranasal antihistamine. And then if they're more moderate to severe symptoms, you may want to do an intranasal steroid alone, or you can combine that with an intranasal antihistamine. Now we're going to begin to review each of the medication classes more specifically. So we're going to start out with H1 antagonists, or our antihistamines. These medications exert their physiological effects by stabilizing the inactive form of H1 histamine receptors, therefore preventing histamine from stabilizing the active form of H1 receptors. Inhibition of this activation results in decreased capillary permeability, reduced mucus production, relaxation of smooth muscle, and reduced vasodilation. The clinical manifestations of these effects reduce sneezing, reduce nasal pruritus, reduce itchy watery eyes, and reduce rhinorrhea. Now that we know how the H1 antagonists or antihistamines work, we have to look at the classes even a little bit further. They come in 3 different generations, and some are over the counter and some are prescription only. But we're going to look at on the next slide a couple of the differences between the first and second generations. The only third generation available is Allegra, but for the most part, the things I want to point out are similar to the second generations. So there's not really anything you need to memorize specifically from that standpoint. Mostly we're just going to differentiate what's different between the first and second generations. So the main differences between the first and second generations are listed here for you. The first generations are cheaper. They're all available over the counter. One of the downsides, though, is that you have to use them every 4 to 6 hours. However, they are highly effective, which is why they're given if someone is having an allergic reaction. A lot of times you'll recommend giving Benadryl or something like that if patient is able to take that, because it is highly effective. However, it does cause drowsiness in a lot of cases, and it does exhibit a lot of anticholinergic effects because there is a higher CNS penetration, and a lot of these effects may be like sedation, dry mouth, urinary retention, constipation, and or blurred vision. And so because of that, we have to use caution using first generation agents in patients who have glaucoma, or if they have trouble urinating, or if they have respiratory disorders, thyroid disease, or heart disease. Second generations are a little more costly. They're still very, very affordable in most cases. Some of the over-the-counter ones that are brand name only are still kind of expensive compared to the first generation ones, but there's still a lot of generic Claritin or Zyrtec available options that are very cheap. They have lots of OTC options and some prescription-only options. For the most part, most of these agents are only used once a day, so that's very convenient for patients. They are pretty effective in most cases, but slightly less effective than the first generation. However, since they are second generation and are a little bit less effective, they do have some benefits such as less or no drowsiness, and less anticholinergic effects, which can be beneficial for lots of our patients, especially the ones I mentioned you have to use caution in first generation agents. They could definitely more than likely use a second generation agent. This slide is just pointing out a unique factor within the second generation antihistamine class, comparing adverse effects with cetirizine, desloratadine, fexofenadine, and loratadine. Basically pointing out here on the slide, I just want to show you that Zyrtec or cetirizine out of the second generation class has been shown to have more drowsiness or somnolence, more fatigue, and dry mouth when compared to all the other ones. So although it is a second generation, you can almost consider it like a generation 1.5, or think of it that way, because it's not quite generation 1 where it's got a lot of drowsiness and sedation or anticholinergic effects, but it does have more than the other second generation antihistamines. So keep that in mind. And generally, if I recommend cetirizine or Zyrtec for someone, I recommend that they take it at bedtime in the event that they do get sedated or that fatigue, dry mouth, that all at night, that's more appropriate, I guess. So typically all the other ones can be taken any time of day, morning or night, but usually cetirizine I recommend be taken at bedtime. So we just discussed our oral antihistamines. So these have very similar mechanism of action. They're just intranasal instead of oral. So the two that I'm going to talk about here are azelastine. These come as prescription only as Astelin or Astapro, and olopatadine or Patinase is available prescription and OTC. The advantages of these are that it's really useful for episodic symptoms, targeted treatment in the nose where a lot of the symptoms are kind of going on. You can pre-treat with these, and very beneficial in patients who are refractory to or not able to tolerate oral meds as well. There's less systemic effects and drug interactions when you use the intranasal route, and the onset is typically a lot quicker. It's 15 minutes usually, and they usually last for about 4 hours, so sometimes these will have to be given multiple times a day. Some of the disadvantages, though, are that they don't really help much with congestion. Since they are antihistamines, they're not going to benefit you as much with the congestion, if you'll remember from the slide above with the pluses. Other things as far as side effects could cause headache, drowsiness, nasal irritation, a bitter taste if it drips down the throat or back of the nasal cavity, and they may have less efficacy over time of use. And then many times these have to be given twice daily. So just to compare the oral versus intranasal, oral onset averages about 150 minutes or just over 2 hours, whereas intranasal is very rapid, 15 to 30 minutes, you'll see the effect. Oral has more systemic adverse effects than the intranasal route. And then also both of these have limited efficacy for congestion, but the intranasal does have a little bit more efficacy compared to the oral. And then the oral is nicer. Usually it's only once a day. Some are twice a day, but majority of the time the oral antihistamines will be once a day dosing, whereas the intranasal are usually twice a day. Next, we're going to talk about our intranasal steroids. Overall, these have really great efficacy for everything that you may experience during allergic rhinitis, minus the eye symptoms. So anything from sneezing, itching, rhinorrhea, congestion, this would be a great choice of agent to use. Typically, they're most effective if you can initiate therapy before the allergen exposure. And the downside with these agents, a lot of times the onset is pretty slow, and maximum benefit is not seen until after about 2 to 3 weeks of use. And a lot of times patients will use these for a few days and then not see any benefit and give up before they reach that maximum efficacy after about 2 to 3 weeks. And they do have a really slow onset time as well. So that's important to let your patients know that it's very different from the intranasal antihistamines, which you'll notice a very rapid benefit in about 15 to 30 minutes. These is very slow. It could be between 3 to 36 hours depending on the agent. And ultimately, you're not going to get the maximum benefit from these until about 2 or 3 weeks. And there's several different agents we're going to go over within the class, but they all have very similar efficacy. just pretty much is going to be down to price or patient preference. There's like I mentioned, not as beneficial for eye symptoms, but can be a little bit of benefit, especially from the anti-inflammatory standpoint. So it may help from like the redness or puffiness, but not as much as with the itchiness. As far as side effects, they may cause some stinging or headache or epistaxis is possible. But ultimately these are very beneficial agents, and you may need down the road to reduce the dose once the response is achieved. But generally speaking, these are very good choices for a majority of our patients. However, it is important to mention that you may want to avoid use of these agents in patients with nasal septum ulcers or recent surgery or trauma in their intranasal cavity. So here's a list of the intranasal steroid options that are available. As you'll see, many of them are available over the counter, and some of them are prescription only. So you can recommend either one based on whatever the patient wants. Many of these are able to be used 1 to 2 sprays once or twice a day, depending on the agent. And then another thing I wanted to point out on this slide too is that some of these agents have a drug interaction with some of our HIV treatments, and which could lead to Cushing syndrome. So if a patient is on HIV treatment, beclomethasone and flunisolide are the preferred agents, and it is contraindicated to use fluticasone, mometasone, and triamcinolone. Like most things, we have to make sure our patients are able to use the product appropriately so that we can assess, make sure it's actually working for them and helping them out with their symptomatic relief. So I included this slide to kind of show the best way to counsel your patient on how they should be using their intranasal medications. This applies to intranasal steroids or intranasal antihistamines, but you're going to tell your patient to start out by clearing their nostrils by blowing their nose. And then no matter what product it is, you'll have to shake the bottle gently. And then instead, a lot of times patients, what you'll see is they'll tilt their head backwards. But what you want to actually tell them to do is tilt their heads forward slightly, as you see in the picture here, number 3. And then what you'll do is put one finger over one nostril and then place the spray pump tip slightly into the nose. You don't have to push it way up in there. And then when you do spray, don't spray it directly towards or onto the nasal septum. You want to kind of just spray it directly straight up or out away from the septum. So because some of these agents, especially the intranasal steroids, if you repeatedly administer the medication right on the septum, you could create a deviation or a cavity between the septum, which you don't want. You want to keep that septum intact. And then ultimately, throughout the process, make sure you keep the bottle upright and pump once firmly whenever you're ready and you've got everything kind of set up, steps 1 through 5. And then as you spray, breathe in through your nose gently, not forcefully. And then you'll repeat these steps with the other nostril. And then also caring for your product is essential as well. You want to wipe off the tip with a clean tissue at the end, and then replace the dust cap to keep it clean and sanitary. And then if you don't use your spray for 14 or more days, you'll need to prime the pump again. So initially when you first get a intranasal product, you'll have to prime it with about 2 sprays before, like I just do it in the sink typically, and then your product will be ready for use. So now we're going to move into talking about our oral decongestants. As we talked about earlier, these are pretty much only effective for the congestion symptoms of allergic rhinitis. The 2 available products we have in this category are pseudoephedrine, Sudafed, or phenylephrine, which is confusingly called Sudafed PE. Both are available over the counter, but pseudoephedrine, you have to show proof of your driver's license and there has to be documentation of purchase of the product, whereas phenylephrine or Sudafed PE, you do not. Side effects of these medications could be increased blood pressure and heart rate, CNS stimulation, or urinary retention. So you just have to be careful with these agents in patients who have uncontrolled blood pressure or things like that, or seizures, things like that. You want to avoid use, again, these patients who have BPH or glaucoma, maybe not the best ideal agent in the elderly or cardiovascular disease, hyperthyroidism, not great in children or pregnancy either. Also another consideration, mothers who are like breastfeeding, it can dry up their milk, so not an ideal candidate to receive an oral decongestant in that case either. And then you'll want to counsel your patients to use them pretty much only when they need them. You don't want to take these around the clock. And because they cause stimulation of the CNS, typically it's better to take these in the morning if possible, because if you take it close to bedtime, it may be difficult to go to sleep. As far as Sudafed, it's available, the pseudoephedrine, it's available in a lot of different immediate release or extended release products, and it could be combined with an oral antihistamine as well, as you'll see that you can purchase behind the counter as well. So comparing these two agents, I think the key takeaway here is that ultimately, since the studies have been done on these agents, phenylephrine has been shown in two different studies to not be more effective than placebo, so I typically never recommend this product. If someone is having congestion, I usually recommend, and if they're not contraindicated to any treatment, I usually recommend pseudoephedrine or Sudafed, which they'll have to purchase from behind the counter, because that seems to be the more effective agent in relieving their symptoms. So you may see this as well, a product called Coricidin HBP. It's marketed as a decongestant alternative for patients who are not able to take pseudoephedrine. It's supposed to help with cough, runny nose, and sneezing. But let's look at what's really in it and whether it's worth it or not. So it's kind of an expensive product, and basically it has a cough suppressant in there plus diphenhydramine in most cases. So honestly, it's probably, if your patient doesn't mind taking 2 tablets, it's cheaper to buy the generics of the active ingredients instead of buying this product itself. For 16 tablets, I think it usually runs about $20, but you could buy each of the individual products for probably less than $5 in most cases. So it's just kind of a marketing thing, and it's not harmful in any way. According to the box, the AHA recommends this product, and it's definitely safer than taking pseudoephedrine for patients who have high blood pressure. So if you're worried that they won't buy the right products over the counter, then you could recommend this product. But otherwise, I think it's probably cheaper to just buy the generic medications that are in this product. So now that we've talked about oral decongestants, we can move on to nasal decongestants. So some of these listed on the screen here for you are phenylephrine, oxymetazoline, and tetrahydrolazine. Some of these are OTC and some are prescription only. The most common one I think you'll probably see is Afrin. The key takeaway on this slide here, I think, is the starred information down at the bottom, is make sure your patients know to limit therapy to 3 to 5 days for these. So the reason for this is that if you use it longer than 3 to 5 days, you'll experience rebound congestion. So honestly, the patient should be using the smallest dose as infrequently as possible. And, try to wean, if patients have been on this for a really long time, they'll have to wean themselves off. They won't be able to really quit abruptly because of the rebound congestion that they will experience from this. So you may experience this at some point in your career, that someone may be, they may think or say the word addicted to this, but more so they're kind of dependent on this, as they are going to experience rebound congestion if they ever stop taking it. So that's something you may have to work through and help your patients wean off of. But ultimately, these products are more effective than the oral agents, and since they have less systemic absorption, they're going to experience less side effects in general that we discussed. Less blood pressure increase, things like that. But they may experience some burning or stinging on administration in their nose, things like that. And these also have really fast onset of action. I don't know if you've ever tried these or not, but they work very rapidly if you have congestion. usually in about 2 minutes or so, you'll notice some relief of congestion. So they're very reliable agents, but the thing is, you want to make sure your patients are aware that they should not use these more than they actually need them. I touched on these a little bit before, but now that I've covered all of the antihistamines and decongestants, I wanted to just list a slide of the combination therapies you may see. A lot of these products are behind the counter. On the top section here, the Claritin D, Zyrtec D, Allegra D, and Clarinex D. These are all combined with Sudafed, so they have to be purchased behind the counter with a driver's license. But these are also very effective one-tablet regimens. Some come in 12-hour formulations and some in 24-hour regimens. That is very nice to have it combined into one pill for patients that don't want to take a lot of different pills. And then also I wanted to mention the intranasal antihistamine plus nasal steroid is prescription called Dymista. I think this is pretty expensive still, brand name only, so you may need to look for coupons or things like that so that your patient can afford it. It's a great medication, but a lot of times insurances may not cover it or maybe a high copay, so that's just a consideration. And this slide here gives you an idea of some considerations you may want to make as you're considering therapy escalation. So if your initial therapy is not enough and you need to add something else onto it or make a switch, this would be a good reference for you to use. So if you're starting with an intranasal steroid and they're still having symptoms and are requesting something else, you might want to recommend adding an intranasal antihistamine or a nasal decongestant depending on what their symptoms are. Likewise, if you start them out on an oral antihistamine, you may want to switch them to a intranasal steroid or an intranasal antihistamine, or you could consider adding a oral decongestant or a leukotriene receptor antagonist. Then lastly, if you start them out on an intranasal antihistamine, then you could consider adding an intranasal steroid on top of their therapy. In this slide, I've listed a lot of the ophthalmic agents that you may see used for itchy or watery eyes or eye redness and congestion. I'm not going to read them all to you, but I have bolded the most common ones that you'll see, and several of these are available over the counter and some are by prescription only. But just keep in mind to use the appropriate one because some of them are more antihistaminergic, which would help more with the itchy watery eyes, and some are more for the congestion and redness. So just pay attention to the correct agent for which you're trying to get the desired effect. And my understanding is that you have a separate presentation going more in depth into ophthalmic agents, so I'm not going to spend extensive time going on to that here. Lastly, I wanted to list a couple other considerations of things that you may use in your career. So we have talked a little bit about nasal saline and its use, and it can be used pretty much in anyone, but it's definitely one of the preferred agents for pediatrics at any age and pregnancy and lactation. So one of the main products I like for this is called NeilMed Sinus Rinse. Basically comes in like a squirt bottle, and it helps decrease nasal congestion through kind of like force. In a way, you kind of like squirt the saline rinse up into your nose, and it kind of helps break up some of that congestion in there. And then you will sometimes see the neti pot being used for a similar thing like that as well. You just have to make sure that you use sterile water. They may need to boil it and make sure they're not putting contaminated or bacteria water in rinsing it through their nasal passages. That would not be ideal. So you just have to make sure they're using that appropriately. Additionally, cromolyn or nasal crom is available over the counter as well, and as well as leukotriene modifiers may be available as RX. These two agents are beneficial for sneezing, itching, and rhinorrhea. And nasal crom, I think its place in therapy is more so as prevention. So if it doesn't work immediately per se. It's best if you can use it in anticipation of an event, such as if you know you get seasonal allergies every March when the pollen counts start to rise. You may want to start using this several weeks prior so that it's working when the time comes that you need it to be effective. I have heard some success with people using it prior to going to somewhere where they know that they're going to be stimulated or have allergic rhinitis symptoms, such as if someone is going to go over to someone's house and they're allergic to cats, this person has a cat. If they use this before they go over there, it may decrease some of the sneezing, itching, and rhinorrhea that they may experience during and after that exposure to the allergen. And for the leukotriene modifiers, also wanted to mention that has similar efficacy to loratadine and additive efficacy if it's added on to loratadine, and it generally seems to be pretty well tolerated. Then as far as immunotherapy and IgE therapies, these you may see in more severe allergic rhinitis cases, but you want to avoid these in immunotherapies in uncontrolled asthma or cardiovascular disease. And anti-IgE may be more suitable if they have the allergic rhinitis with asthma. For the nasal ipratropium, that is available as a prescription as well. It may be something useful to you. So I already talked about this a little bit on the previous slide as the leukotriene modifier, but Montelukast, like I mentioned, has similar efficacy to our second generation antihistamines and has an added benefit if you combine the two. Also has an additional role in helping patients with coexisting asthma, but I did want to mention on this slide too the adverse effects that may be associated with its use. So it may cause upper respiratory tract infections, headaches, or abnormal dreams. And another notable side effect or warning that has been presented by the FDA is neuropsychiatric disorders. So if your patient is mentioning that they've suddenly become more aggressive or more depressed or having suicidal ideation after you put them on this medication, you may want to consider getting them off that therapy or not consider starting therapy on patients who are already experiencing these disease states listed here. So in summary, your treatment should mostly be symptom guided and patient centered based on their age, other health conditions, cost. All that kind of plays a factor into your choice of agent. And then additionally, I just wanted to kind of touch on some targeted approach examples again. So if patients, most of their symptoms are related to itchy, runny nose, then your agent of choice would be an antihistamine here. If most of their symptoms are related to congestion, then your most effective agents would be using a nasal steroid or decongestants, sparingly, remembering the intranasal ones only using for 3 to 5 days. And you could also use nasal saline. It's the safest option in this category. For itchy eyes, ketotifen or olopatadine eye drops would be your preferred agents here in this category. And if they're just having a runny nose only, nasal ipratropium or cromolyn may be your best bet here. So now that we wrapped up allergic rhinitis, we're going to transition into talking about the common cold. The common cold can be confused with allergic rhinitis easily, so I wanted to point out some key differences between a common cold and allergic rhinitis. There is a lot of overlap, but some of the key differences would be things like sore throat. The things that do overlap would be the congestion, the runny nose, but typically the things that differentiate it would be, maybe plus or minus fever, body aches, fatigue, and that sore throat. And typically with colds, that sore throat usually appears first before any other symptoms. And the duration is usually limited, whereas with allergic rhinitis, the duration is intermittent or seasonal, or it can tend to be persistent throughout the year in some people. And onset usually happens around the time of high pollen counts or around the time of certain allergen exposures for allergic rhinitis. So some of the common cold treatment options you have here are zinc or vitamin C that you can recommend. So we'll talk about zinc first. Zinc can shorten the duration of colds, usually by about 1 day if you begin treatment within 24 hours of symptom onset. And the key thing here is that it has to be administered every 2 hours, which can be a nuisance in some cases. Some of the products that you'll see are the Zicam tablets that contain zinc or the Zicam nasal formulations. Some of the things to know, though, especially with the nasal one, that it can cause some anosmia. And then additionally, zinc in general, side effects could include nausea, vomiting, or metallic taste. It is a metal, so that does make sense that it would cause that. In general, it can be helpful, but generally only shortens the cold by about 1 day though. Then moving on to vitamin C, also can reduce the duration of colds in general population and generally contributes to a healthy immune system. And the dose is typically around 2 grams per day. And it also has shown to prevent cold symptoms in a population under high stress as well. So you can use it as treatment and prophylaxis in a way. So here are a couple options for sore throat. You can recommend Cepacol or other sore throat lozenges, or Chloraseptic, which is a sore throat mouth spray. And additionally, you can recommend oral NSAIDs such as Aleve or Advil, ibuprofen, or Tylenol as well. Lastly, we're going to discuss cough. Your cough treatment will depend on whether the patient is experiencing non-productive or productive cough. The difference between the two is if it's more of a dry, hacking cough versus a cough that someone feels they have chest congestion or need to cough up some phlegm. And if it's the non-productive type, then you would recommend more treatment with dextromethorphan or with codeine products. Whereas if it's a productive cough, then you could recommend guaifenesin. So guaifenesin is what I mentioned on the previous slide as an option if a patient is experiencing productive cough, meaning that they have to cough up some mucus or phlegm. And so it's an expectorant, and so how it works is it tries to thin and loosen the mucus to make it easier to cough up. However, there have been some studies done on it to show that it is essentially no more effective than placebo, and it's actually just as good as drinking a large amount of water. And in order to accomplish this, it's not just going to be a little bit of water. Your patient is really going to have to drink a lot of water for it to work. So if your patient is willing to drink a lot of water instead of taking this medication, it should be equally as effective. But if you don't feel that your patient is going to be able to drink an adequate amount of water, then you may want to recommend the guaifenesin in addition to a good amount of water in order for it to best work. And also with this, you're going to want to encourage your patient to try to cough it up as much as possible, because the medication is going to help loosen it up and thin it out. But ultimately, in order for them to get better, they're going to need to cough it up and spit it out. So moving on to some of our non-productive cough agents, I think the most popular one here will be Delsum. It works for 12 hours, which makes it the ideal agent to use right before bed, especially for patients who are coughing at bedtime or don't want to have to wake up in the middle of the night to take another dose. There is another dextromethorphan product called Robitussin, but it only works for about 4 to 6 hours. So that one would not be ideal for bedtime, but could be used throughout the day if patients prefer a shorter duration of action. Additionally, you could prescribe codeine, but just remember that's a controlled substance. It is really effective for controlling cough, though, so you could consider that. Additionally, you could consider using Benadryl or first-generation antihistamine before bed. It can also help with a non-productive cough. Just be aware that the package says it's only for age 6 and up, because not that it's not safe in patients that are younger, but because I think there were some issues with parents using it, giving it to their children to help them go to sleep. But paradoxically, it could actually cause hyperactivity in some children, so you just have to kind of watch out for that and be careful with your recommendation of that. Additionally, you could use menthol cough drops or menthol plus camphor Vapo Rub. Both of these could also be helpful in controlling non-productive cough. And also I wanted to mention, similar to the guaifenesin, comparing that to water, wanted to compare dextromethorphan to honey here, and just reveal that in conclusion, honey seems to work probably a little bit better than dextromethorphan in controlling non-productive cough. So some patients may want to try that, and that's totally fine if they prefer that. So that could be a route you could encourage as well. And you'll see this product too. It's called Mucinex DM. It is a combination of dextromethorphan and guaifenesin. And, I see this product a lot, but I don't know that I recommend it all that often. The product, to me at least, seems a little counterintuitive because the guaifenesin is supposed to help thin and loosen the mucus to help you cough it up. But then the dextromethorphan is suppressing your cough, so it kind of seems counterintuitive. And the best way, I think, to use these products together would be to use a decongestant in the morning, and then the antitussive at bedtime to help with sleep. I think it could be problematic to cough throughout the day, but definitely at night, I think dextromethorphan makes more sense to be used alone. And then you could use a decongestant or guaifenesin alone during the day, but I don't usually recommend this product, Mucinex DM, when combining these two because the mechanism of action just doesn't make sense when used together.
Rhinosinusitis can be divided into viral versus bacterial and acute versus chronic. Viral rhinosinusitis is self-limiting and usually resolves without treatment in 7 to 10 days. Bacterial rhinosinusitis is defined by 3 different clinical presentations, which we'll discuss in the next few slides. For acute versus chronic, acute rhinosinusitis is typically lasting less than 4 weeks, whereas subacute is the period between acute and chronic rhinosinusitis. And then chronic is for patients that have greater than 12 weeks of sinus inflammation. There are 4 cardinal signs of chronic rhinosinusitis, including anterior-posterior purulent drainage, nasal obstruction, facial pain, and decreased sense of smell. Patients would often need to be referred to a specialist if they have symptoms lasting for more than 12 weeks. It's important to differentiate between bacterial and viral clinical presentations of rhinosinusitis since this directs our therapy. As you can see in the graph, viral rhinosinusitis is high in severity in the beginning with a fever, and then decreases quickly over time, whereas the respiratory symptoms increase to a peak within 3 to 4 days and then decrease and resolve within 10 to 12 days. There are 3 clinical presentations of bacterial rhinosinusitis that help us direct our therapy more towards a bacterial cause versus a viral cause. Those 3 clinical presentations include persistent symptoms of 10 or more days without evidence of clinical improvement, onset of severe symptoms or high fever at the beginning greater than 102, and purulent nasal discharge or facial pain for 3 to 4 days. And lastly, onset with worsening symptoms after an initial improvement period, with new onset fever, headache, or increase in nasal discharge. After we've used the 3 clinical presentations to determine that a patient has bacterial rhinosinusitis, we then need to assess their risk for antibiotic resistance. Those risk factors are listed there on the right of this chart. After assessing for risk, we then initiate therapy. If the patient has no risk factors, they can be started on first-line antimicrobial therapy, which we'll discuss in a minute. But if they do have risk factors, then they need to be initiated on second-line antimicrobial therapy in order to overcome some resistance. If the patient has improved on antibiotics in 3 to 5 days, they need to then complete the total course of 5 to 7 days of therapy for adults or 10 to 14 days for children. If they have worsening symptoms or no improvement in 3 to 5 days, it is recommended to broaden antibiotic coverage and then treat for 5 to 10 days total. If the patient has started on second-line therapy, they've improved for 3 to 5 days, you do a total of 7 to 10 days. For empiric antibiotic coverage, it is recommended to use Augmentin as a first-line agent in children and in adults. In those patients that have a penicillin allergy, Doxycyline or a Fluoroquinolone that has respiratory coverage may be considered. Second-line options include Fluoroquinolones, clindamycin, macrolides, Bactrim, Doxycyline, or a second or third generation cephalosporin. Adjunctive therapies for bacterial rhinosinusitis include saline irrigation, as well as intranasal steroids in patients that have a history of allergic rhinitis. As far as symptomatic treatment, For pain and fever, we can use NSAIDs such as ibuprofen or acetaminophen. Decongestants are not recommended in bacterial rhinosinusitis. However, if a patient has viral rhinosinusitis, these agents may be used. The antibiotic of choice in bacterial rhinosinusitis is Augmentin, which is composed of amoxicillin and clavulanic acid. Amoxicillin is a bacterial cell wall synthesis inhibitor and binds to penicillin binding proteins, or PBPs, to inhibit cross-linking of the cell wall. This leads to bacterial cell lysis. Clavulanic acid binds to and inhibits beta-lactamases that are produced by the bacteria in order to inactivate amoxicillin, and therefore results in amoxicillin having an expanded spectrum of activity. The main side effects of Augmentin include diarrhea, GI upset, and rash. It's contraindicated in patients that have penicillin allergies due to the fact that amoxicillin is within the same class of penicillin. For patients, it is important that they take the medication with food in order to reduce upset stomach, and there's also a suspension available for children. The next class of antibiotics we'll talk about are fluoroquinolones. They inhibit bacterial DNA topoisomerase 4 and DNA gyrase to prevent DNA supercoiling and promote DNA breakage. This leads to cell death within the bacteria. There's agents that are separated into respiratory fluoroquinolones that have coverage for strep pneumo and non-respiratory fluoroquinolones such as ciprofloxacin. All fluoroquinolones have black box warnings, including one for tendon inflammation and/or rupture. This is more likely in patients that have concurrent systemic steroid use, organ transplant patients, and patients that are 60 years or older. There's also a risk for peripheral neuropathy that can last for months or years after drug discontinuation. And lastly, there's also a black box warning for CNS side effects, including an increased risk of seizure. Adverse side effects of these medications include QTc prolongation, as well as increased photosensitivity while on the medication. For patient education, you want to educate them to separate these medications from polyvalent cations, such as calcium or iron, etc., by 2 to 4 hours. Also, fluoroquinolones can have an effect on blood glucose, so our diabetic patients will want to measure their blood glucose more frequently. The last antibiotic we'll talk about for bacterial rhinosinusitis is doxycycline. Doxycycline inhibits bacterial protein synthesis by reversibly binding to the 30S ribosomal unit. The side effects of doxycycline include nausea, vomiting, diarrhea, as well as increased photosensitivity. It's important to educate our patients on taking this medication with a full glass of water and to separate it from polyvalent cations by at least 2 hours. We'd like to avoid doxycycline in children less than 8 years old and pregnant and breastfeeding females due to the risk of doxycycline causing tooth discoloration in maturing teeth. Intranasal steroids are first-line agents for moderate to severe rhinitis. In this table, you can see the generic and brand names of the different intranasal steroids, as well as the dosing for adults and children. The most common side effects of intranasal steroids include headache, dry nose and nosebleeds, as well as unpleasant taste. It is important to educate patients that these medications may take up to 1 week for full effect. Budesonide is the preferred agent in pregnancy, as well as when they're using the medication, they want to point the tip away from the nasal septum. Decongestants may be helpful in patients that have severe nasal congestion. Systemic decongestants, such as phenylephrine and pseudoephedrine, may be reserved for patients that have more severe symptoms, whereas topical decongestants, such as Afrin, may be used in patients that have moderate symptoms and only require a few days of use. We want to avoid the use of decongestants in children less than 2 years old. For our oral systemic decongestants, we want to use caution in patients with cardiovascular disease, uncontrolled hypertension, since these agents can increase blood pressure, hyperthyroidism, because they can worsen hyperthyroidism, diabetes due to the increase in blood glucose, bowel obstruction, glaucoma due to the increase in intraocular pressure, BPH, since these agents can cause urinary retention, and in the elderly. We want to limit the use of intranasal decongestants to less than 3 days due to the fact of rebound congestion. The most common side effects of these agents include cardiovascular stimulation, CNS stimulation, as well as headache and dryness.
Hello everyone, my name is Chris and I'm one of the PGY1 ambulatory care pharmacy residents at Moses Cone. And today in this presentation we're going to be discussing allergic rhinitis, cold, and cough.